Join us as we explore evidence-based practice, manual medicine, and sports science through the lens of movement, strength, performance, and overall health.
All right, welcome to the podcast, episode 5, is it?
5 or 6.
Man, I'm losing count. I suppose it's a good thing, eh? Obviously, as always, co-host Dr. Stephen Redmon. I like to call it Redmon or the Tony Stark of Chiropractic. And I am Brogan Williams. And today we're going to talk about some hopefully interesting things that are not only going to help you as a coach or a clinician, but maybe it's going to be entertaining as well. I suppose that's always the goal, isn't it, Stephen?
Yes.
First things first, I've had a lot of people ask me on my Instagram, believe it or not, how I made this. Well, I've had some people ask me where I got it. Now, I don't know if they're just being polite. You can clearly see it's handmade. But I made this with, if you go on Andrew Locke's website, in his seminar, he teaches you not only to draw the vertebra or a lumbar vertebra, but he also teaches you or encourages you to go away and buy some of the materials, some of this fast-acting drying clay, and do it yourself. So it's not perfectly anatomically correct. It's like an L4-5 type vertebra, maybe more an L3 or 4. But you can see I've got the nerves there, recurrent nerve running up into the discs. Got the main one, dorsal ventral coming out the sides here. We've got coming onto the TVP, coming out here onto the spinous process. I did ones coming out here going to the spinous process, and then I forgot to do ones going to the facet. So I was like, oh well, the medial aspect of the posterior rami. That's the nerve that runs to the facet. I'm like, remember I text you and I'm like, hey, what do you use? What do you call the disc one? Like the recurrent or the meningeal? You're like, whatever comes first.
Yeah.
Like, everyone just uses it interchangeably. It's hilarious. Anyway, so this is just fast-acting clay, and then this is like a soft foam. So I do encourage anybody, like if you have the time and care about it, to give it a go. Not only is it cheaper than buying these like hundreds and hundreds and hundreds. Do you have yours on hand, by the way?
I don't have it on hand.
You've got a proper
in my office.
Yeah,
I do.
You've got a proper one, which are way better, obviously, but these are a little bit cheaper. This probably cost me like $5 or whatever to make. I do want to get a proper one because you have the full-on like herniated mechanism, disc herniated mechanism.
Yeah, I have the fancy $300 one that does all the things.
Oh, 300 American, that would be like 500 New Zealand. That's a stretch, man. I mean, they are the best in the world, though, right? So dynamic disc designs, right?
Yeah,
sure. And the other ones that Stu McGill used as well. In fact, like they've designed some of this based off some of his research and how the disc works. So that's pretty cool. But yeah, no, it's been a while. Well, I suppose it hasn't been a while. Like, we've been dropping episodes since we've started every kind of 1 to 2 months. Had some really good guests on last time. It was cool to have Luke and Brent on, and lots of support and positivity from that podcast and from the clips that we posted on social media. So if you're listening to this we're on Google now, which is cool, like on the Google Play, I think it is. So we're obviously YouTube, Apple, Spotify, now we're on the Google Play, and then obviously our Instagrams and our social medias have clips posted to it. So if you're listening to this on one of those platforms, be sure to follow us on Instagram, so that you can also get the highlights, because I find a lot of people connect with those highlights, and it gives us a platform where people can actually comment back and give us their opinion, which has happened before. I've had people ask me questions and I've just tagged you in it. Yeah, Stephen can answer this question. He was running his mouth. It's not my problem. He can answer. But sometimes it's easy for us just to like say our opinion, because there's no back and forth. And so it's cool to have that. I interrupt this podcast to thank Rehab for sponsoring the Strengthandchiro podcast. Rehab is a family-owned New Zealand business that only produces high-quality, all-natural and clean products. If you're anything like me and you need a protein that tastes good, mixes well and contains no additives or nasty preservatives, this is for you. This protein is New Zealand-made, ultra-filtered, gluten and GMO-free with no artificial flavors or colorings. If you are an athlete or you love to train hard, it is essential that you get an adequate amount of
protein. We would like to thank Raisies once again for sponsoring the podcast. You can get 10% off at raisies.co.nz.
First thing I wanted to talk about today and get your thoughts on, Dr. Stephen, being a chiropractor. Recently, I've been doing some cool collaborations and chatting a lot with a neurosurgeon in Australia. So he's a neurosurgeon. I'm pretty sure he's in Brisbane, and we did a collab infographic. And basically, the cool thing about doing these types of collabs is that you just kind of ask. I kind of asked the person. I said, "Okay, what's some of the most important information you would like to get out there?" And the cool thing that Dr. David Johnson is doing is that although he's a neurosurgeon, he's also a functional movement coach and a CrossFit coach, and one of the only people in the world that's been able to integrate a functional movement gym, CrossFit gym, into his actual system of rehabilitation with his patients. One of the interesting things that he talks about is the 4 pillars of health being movement, sleep, nutrition, and stress management. So movement, sleep, nutrition, and stress management. But he also talks about the differentiating between exercise and quality functional movement. So his idea of quality functional movement would be compound multi-joint functional movement patterns under load coupled with competent technique. And the reason why he differentiates between that is because he believes that in order to combat chronic disease, and especially musculoskeletal disease and pain, we have to have people not just exercising, so not just moving, but moving well under load. So exercising under load, right? Resistance training. And we have so much research now showing the benefits of resistance training. So not just cardio, not just moving, but actually being able to move under load. And in order to do that properly and get the best results, you have to move under load well. And so that's something that he's been talking about and really resonates with me. And he goes on to say, in medicine, 90% of the disease burden would be preventable if we had clinicians out there pushing these 4 pillars of health. So with you, in your experience, Dr. Stephen, seeing patients over 2 different practices that you work in, how do you approach that communication aspect beyond just what you're doing and how you're adjusting and how you're treating the patient? How do you approach communicating these pillars, if you do use these pillars, if you agree with them? Like, I'm happy to hear your thoughts on it. And how would you go about that? And how important do you think that is personally?
So these 4 pillars that Dr. David Johnson is referring to are pretty well established to some degree. Some of the verbiage is used differently with different people, but I absolutely do practice where I talk about movement or physical activity or exercise, sleeping well, nutrition, and stress management. Obviously, there's good stress, eustress, and bad stress, and I discuss those as well as how all of that is a variable into why the patient is feeling the way they are, why they're not getting better, why they are getting better, and how it can help improve their progress or how it can impede their progress. And a lot of times, like, I don't mention this on day 1. I'll mention like some of it, and then as we go through with each visit, I'll introduce more and more of it as we go. Because honestly, after like the 2nd or 3rd visit anyways, the patients tend to have a lot more trust in me, and they're asking me what are things they can do outside of the visit to do better. And that kind of opens up this whole expansion into those 4 pillars of health, where you can really like deep dive into that with the patient and help them kind of self-evaluate where they're at in each of those pillars with their life and where they can potentially improve it, where they potentially maybe can't improve it. I know this kind of also just ties into a video that Dr. Mike Gardino posted about his rehab pills. Like with the 4 pillars of health, like if people aren't moving better and they're going to come up with excuses why they're not moving better, they would theoretically want a rehab pill where they can just take a pill and get the movement done for them. And I discussed the limitations of the fact that they perceive there's limitations on their ability to move. and we try to find a happy medium for them. If not, then they just have to accept that there are some things that they need to do better with, or they may not get the results that they're looking forward to. And this doesn't, I know there was a whole thing at one point not too long ago where Stu McGill said something a little bit more aggressive, and some of the pain science zealots like jumped on him saying that he like told the patient they deserved to have the pain because they didn't do the right things. And I don't, that's not exactly where I'm going. Like, obviously, if they're not increasing their movement, it doesn't mean they're not going to be able to do anything and they're just going to completely plateau. But it is one of the 4 foundations to getting better, to maintaining a healthy lifestyle. And we want to encourage some degree of movement, and we want to continue challenging that movement as well, whether it be under load, under new just movement habits in general, like gamification of the movement to inspire them to move better.
Yeah, I think with the Stuart McGill thing, it's a lot of the time people will see like a clip, or they'll see a YouTube or a short format clip on social media, but it's really understanding his whole, once you have an understanding of his whole method, you have an understanding that he will see, he's not rushing through patients by any means. And it's so easy when you hear stuff like that to go, oh, he's telling people it's their issue. Like this is not how you treat people. And the very people that are saying that are the ones that are seeing their clients for 2 minutes or 4 minutes, or, it's like they're freaking cracking and racking. Or you've got physios that are seeing them for 10 minutes and doing cross-frictional massage on scar tissue. Like, these are the guys that are complaining about McGill saying, being a little bit rough in his verbiage. Here's the thing. It's context, because we know that by the time you're seeing the leading voice on lower back issues in the world, by the time you're seeing Stuart McGill, you've gone through a lot of clinicians likely. It's kind of that last ditch effort in a sense for many people. And I think that's why he understands the power imbalance. I think, and he uses it to his advantage to, I don't want to say scare, because I know that's a negative way of saying it, but to kind of reinforce the importance of that they need to take responsibility for their action, or they're going to be in pain for the rest of their life. And it's sad, but it's true in a sense, because we know that 70 to 80 to even up to 90, depending on different parts of the world, percentage of population are going to have an incidence of lower back pain in their lifetime. And it's going to, a lot of the time it's multiple, it comes back, people deal with it throughout their life. Sometimes it moves into that chronic region and people can't seem to get rid of it. And they're not willing to put in the work, like going back to that video, and we'll play that video in a second. Would you take a rehab pill for $2,000 when, that's going to give you those results, when you can actually take the responsibility and do the work yourself? And it's quite confronting. So I think in that context of how Stuart McGill was talking about it, it makes sense. Within the context of being, the first point of call, or the first clinician you see, or a GP or a physio or a chiro, first person you see with pain saying that, I understand why that may be inappropriate. It is also interesting what you mentioned about explaining distress and eustress, because doesn't it have a direct tie-in to what we're doing as clinicians and coaches when we're trying to rehabilitate people? The source of that motivation or that quote unquote stress, it directly impacts it. So with a lot of people will say, hey, you're not a psychiatrist, like you're not a psychologist, you're not a counselor. We understand, anyone that's done some research about pain, understand that it's highly complicated, very complex, right? And it's associated with many parts of the brain and many things, many variables about that human, what they're experiencing, what they've been through in the past, how they're feeling on that day. We're talking emotional things, we're talking about physical things. So when it comes to explaining that to your patient, obviously you don't have long. How would you explain hopefully I'm not putting you on the spot, but how would you explain the eustress and the distress thing? A really powerful way of describing the motivation behind why people do the things they do, and how to look at that emotion and that motivation in a positive or a negative light, with negative or positive connotations.
Yeah, so some of the distress out there is stuff that can be immediately controlled, some of it's stuff that can't immediately be controlled. And I make sure to discuss all of that. So like certain times, like, I mean, honestly, like the last couple of years, politically, like geopolitically speaking, like there's been a lot of distress in the world. And that adds up. People have had to change careers. People have changed the way their lifestyle is. Some of them are now working in a very different setting, doing the same thing they were doing before. Some of them are starting to reintegrate back into whatever work setting they were prior to the pandemic's onset. And I discuss how all of that can potentially affect things. Like they might have been sitting in a desk 8 hours a day for years and years and years and years. And now they're sitting on their couch.
Yep.
And so obviously they're literally just sitting on their couch. So they're not moving at all for the most part. They'll even say that they're like hunched all over in these weird positions for long periods of time. That can create some distress in the body. I discuss how getting them to sit up and stand up a little bit. My thing that I kind of anecdotally push on patients is a sit-stand desk. I know in undergrad in my ex-phys class, my group did a really big project. I mean, the whole class did, on the benefits of a sit versus stand desk. And so I was like, hey, we're going to do both of them combined and suggest that they do both sitting and standing. And we look at all the things that happens with that. And so I like to suggest like 40 minutes of sitting, then 20 minutes of standing for halfway through however long they plan to work, whether it be 2 hours, 4 hours, 6 hours, 8 hours, and then halfway through that time frame, flip it around. So then the one they were doing for 40 minutes, they'll do it for 20 minutes, and they'll do vice versa, just to keep things moving, keep things active, just keeping the brain distracted enough to where it doesn't kind of plateau neurologically speaking, like stimulus wise. They're able to be very aware of their surroundings, work more efficiently.
Yeah.
And that in turn creates like some eustress, some good stress, because now they're getting up, they're moving a little bit. There's a little bit of some metabolic changes that happen there. They're just moving and they're a little more aware of their surrounding. The research does show the more you move, like the more happy you are, the less distress that you're going to experience when you're up and moving around. So I discuss all of that, obviously a bit quicker than what I just explained.
Yeah.
Really care about the science behind it. Some of them are just like, oh no, that makes perfect sense, I'm going to do that.
Yeah, and I suppose that's part of the job, right? Like we go through college and we get taught how to understand anatomy and all this dense information about neurology and whatnot, but so often the ability to communicate is brushed over. I've heard students like communicating and just being like, what are they saying? And to be quite honest, I've been in the same position. We know communication is so important because it's one of the leading strengths of what we can do as coaches and clinicians when it comes to helping people with health and with healthcare, or should I say sick care, because we understand that, like the intervention that you're going to apply, whether it be you're a physio, an osteo, or you're an AT, a GP, whatever you're doing to help that person is important. That's the intervention. But the ability to educate about lifestyle, educate about some of these major pillars that we understand, like you said, they're very established. And it took a long time to establish these things, just like it took a long time to establish that smoking was bad. You can still watch movies from 20, 30, 40 years ago and people are all smoking still. And it's like the jury was still out on how bad it was, because it was so difficult to find the right type of research to find those causations. And the interesting thing with this is we understand, like you just did a really great job talking about stress, but we understand stress, sleep, nutrition, and then now we know exercise, and now even exercise under load are all major pillars when it comes to building the components of a healthy life. And if you can communicate that efficiently to your patient, think about how much good you've done beyond just your intervention. And a good example of this is one of our mentors, one of my lecturers once said to me, if your patient comes in and they tick on the history that they're a smoker, the best health outcome you can do for that patient is to talk to them about their smoking. right? Like the best thing you can do is to, ideally in a perfect world, get that patient to stop smoking. Now, in reality, is that likely? It's probably not likely, because the person's probably been struggling with this addiction for a long time. But doing that and doing it well, I still believe is important and should be done. I still think the doctor is part of his role to at least acknowledge it. I understand that's a really hard thing to do, and it's really hard to communicate to your patient. And it gets even more of a slippery slope when we talk about obesity, especially now that we have people promoting it, right? Promoting plus size. And it's a really slippery slope when it comes to a GP discussing these things, or any type of healthcare person discussing these things. Obviously, it's different in different contexts. Like I understand, like in a high volume place, you're not going to be calling everyone out for every issue they have. I understand that. What I'm trying to say is that if you've got someone coming to see you as their primary healthcare provider, they're seeing you for a long period of time, being able to communicate and being able to educate is an important part of the process. That's what I'm trying to get at the end of the day. Sometimes it can be awkward, sometimes it can be hard. Doesn't mean it's not important. Another thing I wanted to touch on is the fact that the human body, believe it or not, does a fantastic job at compensating. And by the time that someone's walking or limping through your door, and they've got pain, they're far beyond that threshold of where their body ceased to compensate effectively. They've likely had dysfunction going on for a long time. It's just it wasn't at a point where it was presenting physically, right? So being able to also teach people, hey, once the pain is gone, because a lot of practitioners, a lot of chiros, physios and whatnot, they're very confident about getting people out of pain. But, oh yeah, we'll modulate your pain. We've got a lot of tricks to do that. And we know, right? Massage, dry needling, adjustments, all these different types of things, they do all modulate pain in some way or another. Some are better than others, don't get me wrong, but they all, at the end of the day, modulate pain. So a lot of clinicians are confident on that. But how confident are we about addressing the core dysfunction and communicating to the patient, once the pain's gone and you stop seeing me as a clinician, we need you to upkeep some of these lifestyle factors, right? Sleep, nutrition, the pillars once again, and then touching on what you said, talking to the person about how they're sitting. If they're sitting for 8 hours a day, if they say they're doing a 9 to 5, every single week they're doing a 9 to 5 shift and they're sitting on their ass, talking to them about finding ways to change that cycle, extremely valuable for that person. And that's going to help them stay below that threshold, that needle of, allowing their body to continually compensate to the point where things aren't getting out of hand and they have to wobble through the door because they've got sciatica down their bloody leg again. So all important things when it comes to those conversations. One thing is I've found interesting, and I'm keen to hear your thoughts are, it was very common in the early years to demonize posture. And what we did is we demonized certain postures based on certain studies, right? So we were like, hey, we know how a disc acts. We know the mechanisms of a disc now. So if you're in flexion, under load, or compression, or even just from your body or your head, like with your neck, if you're sitting, you're extending, or then you're flexing, or you're sitting out like this, or your back's rounded, we made these like global statements. That's a bad posture. And then now the research has shown it's not so much as one bad posture, but more that staying in one posture for too long is bad. And I agree with that. But it's interesting because there must still be a threshold where certain postures are more provocative. In your opinion, what postures are more provocative? Not under load, just straight posture.
I feel like it still kind of goes back to those postures that we thought were bad. I don't ever talk to people about bad posture.
Yeah.
I talk to them instead about just moving more. Like the only bad posture is the posture you stay in for too long.
Yeah.
So, I mean, really, if you stay in any position too long, like I had a patient tell me their brother-in-law just recently broke multiple cervical vertebrae going head first into the beach out in California.
Yeah.
And then he had to fly back to France, back where he lives. And he had to fly back with a neck brace. So he was in perfect posture. And he was not. He was on a bunch of pain meds. But he was in a lot of pain. His whole body was completely rigid after that flight. Because really any posture, if you do it for too long, can be too much. I mean, heck, even just over this weekend, I had 2 days off for the first time in a couple months. So I went to bed a little early, slept in a little late. So I was in bed for quite a while. Probably I was asleep probably about 9 hours, probably in bed for about 9.5 hours. And I have a very nice mattress. I sleep pretty good in it. I don't ever like toss and turn because I can't sleep good in it. But this morning when I finally got out of bed, my back was aching because I was laying down for an extended period of time. So as soon as I got up and started moving and started feeling a little bit better, took a shower, ate some food, went on a 1.5 mile walk with my dog, and came back, and kind of my normal low back pain that I have, like nothing like that achiness that had onset from that morning was gone because I was in a different posture. I mean, I wasn't sure we like jogged a couple of minutes, but for the most part, I wasn't straining myself too much. I was just up moving around. My dog doesn't really pull. I pull him more than he pulls me. But it doesn't take much to get out of a posture and create a dynamic posture. I talk way more about dynamic postures than a static posture. I know, like in school, and the massage that I teach, and I talk about static postures as an assessment tool, but then I say that we need to be more concerned about their dynamic posture just because they have maybe a high shoulder and anterior head translation, which everyone tends to have. It doesn't really mean anything unless it's causing dysfunction for them. And by moving around more, you can find out if it is truly a dysfunction or if it's something adaptive to help them do whatever they need to do.
Yeah, and there's research showing that there's no direct causation between x-rays that show a reverse curve in the cervical and pain.
But good luck telling that to someone who is so sure that the reverse cervical curve is causing their pain.
But
that's like talking to a wall.
Exactly, but a lot of people wouldn't even know anything about that until they walk into their car office and the chiropractor pulls out the big scary x-ray and shows them that this is what it's meant to look like and it's not looking like this, and the person feels like they're being told they've got stage 4 cancer, like they've got a diagnosis. It's terrible. It's like fear mongering, and then that person, they do the perfect layup to that whole notion around them having an issue with their spine with the old wellness, well, the old payment plan followed by wellness, and I suppose that's where a lot of that can come from, right? People can get this idea around, hey, there's something wrong with me, when there really isn't. And I've got a little bit of an anterior C2, nothing significant. Didn't come back on the DACPA report. So people that don't know what that means, didn't come back on the X-ray report by the professional. But the chiropractors looked at it and go, oh, C2's forward. This is causing all your problems. And that's after 2 years of doing direct P to A thrusts into my neck, punching me, and me leaving the center with migraines and agony. But the thing is the way I was communicated and the way it was shown to me on X-ray, it truly felt like something was wrong with me, And I remember at the time, I even screenshotted it. I think I sent it to you and Mike, and I sent it to a few other people, and I'm like, I'm okay. Everyone's, yeah, it's fine. Dr. Mike Woodbury, he literally goes, he's like, yeah, you're fine. He's like, just do some strengthening work if you feel you need to. He's like, stop stressing about it. I'm like, yeah, good point. But it's so easy for me to associate my past with dysfunction. So immediately they say to me, what have you done in your life? And you get those ones. Oh, this X-ray. Have you had a fall? It's like asking someone if they've had a fall. It's like asking someone if they drink water. It's like, yes, they've had a fall. It's just so funny. I've seen it play out on Instagram 1,000 times, right? And it happened to me. What have you done in your life? And then, I was a powerlifter. Oh, how much weight? Why I squatted 400 kgs. all that. Oh my gosh, yeah, that pushed your neck forward. That pushed your, it's just like, no. Like, you can't prove that. But that's a very powerful narrative to put into someone's brain. And even someone as myself, strong-minded as myself, it kind of threw me a bit. I was like, hang on, is there something wrong with me? Like, is my neck going to slip off when I'm 40? I remember saying that to the car. I said, he goes, "Oh, you're gonna have to look after this, so it's gonna like it'll go the full way." Because go what full way? Like, what do you mean? Like, my neck's gonna slip? Like, how's it gonna slip? Like, what do you do? Like, there's the dents. Like, you got the odontoid process right there. Like, what's gonna slip? Also, okay, so what you were saying that I really liked overall, motion is lotion, right?
Yeah.
When it comes to being human, I put up a meme actually about a dog lifting weights. Did you see that?
I did not.
It was talking about whether a dog should lift weights like belly
Oh
up
wait, no, I did. Yeah,
or
because he
on
had the
all
bar.
fours.
Yeah,
And I was like,
yeah.
all fours, man. I was like, all fours, better mechanically, more weight
Yeah,
lifted, less
biomechanically,
range
it's
of
more
motion.
advantageous.
Absolutely. And right, same thing with us. We're bipedal, right? So bipedal locomotion, in the words of the great Stuart McGill, is the balm of the back, right? So get out of your chair, go for a short walk. If you're sitting in your desk and you're stuck and you have to be there for meetings, and I remember when I worked a desk job, I would have clusters of meetings, so I wouldn't be able to get out for like 4 hours. But once I was out of that cluster for the remainder of the 4 hours I was at work, it was like every half hour I was doing a 5-minute walk. Even if it's to get a water or a drink or a coffee or whatever, you have to be mindful about your musculoskeletal health, because you only get one body. The older I get, the more I'm focusing on some of those basics, like I'm focusing on making sure that I'm moving more. The nutrition is in check. The sleep. I mean, my son wakes up like 5 times a night. And I suppose that's a season that all parents have to go through. It's like, how can we combat this? Like, how can we work through this season with my son? We've got a sticker chart, right? And it's, if you sleep through certain nights, you get a sticker, then you get a toy. It's employing strategies so that he sleeps better, so that I sleep better, so my wife, everyone's sleeping better, because that's a pillar of health. It's the nutrition, it's the training, right? You got to worry about this stuff as you go through life. Another thing I wanted to say is, absolutely, there's no right posture, but there is a right posture under load, and that's where I draw the line. And I think you have agreed with me in the past, but really, when it comes to loading the spine, that's when posture does matter. And also, I would say, even unloaded, where posture matters is when someone's already been injured versus with a healthy person. So if you've got someone that has no problems, then it's pretty fair to say, hey, look, no posture is a good posture. Make sure you're moving lots, staying healthy, hydrated, eating well, blah, blah, blah. However, once you have an injury, that is when some positions can be more provocative than others. And that's when you kind of have to understand the mechanism of why things occurred in the first place. And that goes directly into this ridiculous ideology or belief system around non-specific low back pain that so many people cling on to. That is disputed by Stuart McGill, because if you read all his books, he's huge about going in and trying to locate the mechanism of why there is an issue. Sometimes you're not going to always get it right, but at least know enough to be able to chase it down and to try and have an accurate DDX. I recently heard a physio saying in an Instagram comment, it doesn't matter what it is, because we're just going to treat it the same. This is literally what they said. It doesn't matter what it is, because end of the day, the rehab process is the same. Like, if your hip's not moving properly, I'm just going to we're going to rehabilitate you back with hip flexion, extension, external rotation, abduction, or in a squat or in a single leg stance. Like, they have their rehabilitation protocols so set, just like a chiropractor has their adjustments so set, or some of them, can't lump them all in together. And just like an osteo might have them, I was just talking to you about how osteos have their set, some have their set 15-minute MET, 15-minute mobilization. MET is just a PNF for people that don't know what a MET is. But it's like, yeah, you have to have the ability to be able to kind of adjust that. You can't just do the same thing. I wanted to play this video. Yeah, this is Dr. Mike. We had him on the podcast a few episodes back. And I think although this is like a funny video, just for social media, I think he kind of touches on something pretty important. So let's have a listen.
All right, so your homework is to work on those rehab exercises.
Doc, I just don't think I have the time to do them.
Well, there is one alternative.
What's that?
These.
Those?
It's got the goods.
These.
What are those?
Rehab
pills. Take one in the morning with breakfast, one at night with dinner, and you're good to go.
Well, how much is a bottle of those pills?
Well, a bottle like this with this many tablets will probably run you about $2,000.
And how much are you going to charge me to do the exercises?
Those would be free.
All right, I'll take 2 bottles.
Oh, he's a happy chappy. He's more than happy. Eh?
Oh yeah.
He's like, yeah, I'll take 2 bottles. I'm like, give me 3, give me 4 bottles. So obviously a joke, but man, how have you come up against this in your experience, and what are your strategies to help with adherence when it comes to the programs you give your patients, or even just the simple advice you give them when it comes to taking control over their own health? Because you see them for half an hour and then they have another 23 and a half hours of the day to go off and do and unwind what you do, you know? So just going back to what we talked about recently, the importance of education and the importance of communication, but more so, how would you directly deal with this type of thing? And have you seen much of it as well? I'm interested in it.
I deal with it kind of the exact way you just mentioned. I remind them how little time in the grand scheme of things that I spend with them. Like overall, they're with me just a microsecond of their life, and everything that they do outside of the little bit of time I get to spend with them is either going to positively influence what we're doing in my room, or it's going to negatively influence what we're doing in the room. So the more they can do to help build from that and get better results collectively with what I'm doing a little bit and what they're doing a lot of it, will lead to better outcomes for them. But at the end of the day, some people don't want that. Some people truly do just want to feel like they're being taken care of. And so I know that also leads to a whole thing where people are like, you shouldn't use passive modalities, but passive modalities do modulate pain. They help people feel better. There's some good benefits to it. If people aren't going to adhere to a treatment plan, I'm not going to be like, well, I'm not going to see you anymore.
Yeah.
I will remind them that there are things that they can do. I will help them try to regress it and do as little as possible at the very beginning, just to make them feel empowered that they have the time and the capacity to do something that will help them in the future. And if at the end of the day they still don't want to do that, then I will occasionally bring it up, just checking in, seeing how things are going, and I'll continue treating them. But they are under the understanding that the results we get may be extremely limited compared to where they could be if they took a more active approach to their complaint.
Yeah, and the thing with what you touched on with passive modalities, there are people that use passive modalities well, and there are people that use them terribly. There are people that use active modalities well, and people that prescribe them also terribly, because an active modality that is poorly prescribed is going to have a poor outcome, and possibly even a more adverse reaction or effect if it's done wrongly. If people don't understand biomechanics, I like to call it applied muscle physiology and biomechanics, because that's exactly what it is. We're applying these principles to a person, right, to actually how a person is moving. And before you even mentioned with posture, yeah, we can talk about how someone is sitting all day, which is important, but how about we talk about how someone's moving? How about we talk about how they're moving in the gym? Walking is one thing, right? Bipedal locomotion, important. How someone's sitting, all that stuff, important. But if your patient is taking your recommendation to go into the gym and train, and then they're training without proper technique, you're going to be doing more damage than you're going to be helping. Loading up the weights and not being confident in the technique that is required is never going to be a good idea. And there are many people out there that say, hey, we want to promote movement. We don't want to fearmonger people and tell them, oh, lifting with a bent back is going to hurt them. I totally understand the importance of encouraging movement. And that's exactly where I come from. That's where Dr. Aaron from Squat U is coming from. That's where Dr. Andrew Locke from, in Aussie, that's where he's coming from with his principles. Stu McGill, all these people that I chat to, they all want to promote movement. In fact, they're all passionate about it. But the disconnect is that you cannot tell somebody to pick up a heavy amount or prescribe someone to pick up something that's really heavy, right? Because you're trying to help them, rehabilitate them, or you're trying to get them stronger or healthier. You're trying to work on those 4 pillars of health, but then fail to mention how to do it properly. Or, and this is the more likely thing that happens, is not have the education or the understanding of applied physiology and biomechanics to actually be able to help that person move properly. And that's where we go into what we talked about on the last episode, where being able to reverse sideways, I'm not even going to say downwards, so sideways to a strength coach is very, very advantageous if you need it. If you have an exercise physiology background or exercise science background like yourself and you understand lifting, that's fine. You've got that skill. But there are clinicians and there are people out there that don't have that understanding, and they will go ahead and prescribe movements that are not actually going to be helpful for the patient, because the patient goes into the gym and they just load on the weights. I've seen this play out so many times as a coach, and it's so important that everyone needs to come together on one thing: pain science, movement specialists, fundamentalists, biomechanic heads. We all need to come together on one thing: movement matters, right? We can all agree that movement matters. We can all come together and say we want our patients to exercise. We want our patients to resistance train. The research is there. But where there's that disconnect is certain people saying, well, your technique does not matter. And that is the problem, because we absolutely know that how you move under load does matter based on the mechanisms we've seen of injury. We understand that hyperextension can cause the facet issues or bony structure issues or spondy issues. We understand that flexion and load can cause issues with the disc. We've seen these mechanisms play out in studies. People try to attack those studies by saying, oh, they use pig cadavers or they use lamb cadavers, or it was unrealistic the amount of weight that they put on that. All of that may be valid, but the mechanism at play was still true. It's like if I say reverse stress strain reversals on a lumbar spine under load will cause an herniated disc. You can't dispute that, because regardless of the variables, that's what happened in the study, right? Like that happened in the study. So people often take those words and then they rewrite this big narrative and they misrepresent your position, and they go on this big, wonderful playland, psychedelic little journey of their own, because they're trying to strawman your argument without actually being able to understand what you're trying to say. At the end of the day, I think as allied healthcare professionals, we need to find more common ground. And I think that common ground is going to be movement, but then being able to also listen to the other side and to be able to not misrepresent what they're saying and just attack what they're saying, because it doesn't help anybody. I'm currently working on a blog with some of the guys, and we're trying to explain our position on posture under load in a way that's going to make sense to everybody, in a way that's non-combative, and in a way that is open to change or open to us being wrong. Because I think everybody has to be open to being wrong. If we're all so obtuse and stuck up and stuck in our own ideologies, we're never going to move forward. So that is a massive thing. Going back to what we're talking about with the passive treatment, there's 100%, I went out on a tangent, but it's all good. It's our podcast. We can do what we want. The thing with passive treatments, like you said, fantastic, right? They can help modulate pain. They can help increase range of motion. They can help the patient confidence, right? You feel better when you have someone caring for you. So that's very valid. Now, when you start moving over into spinal manipulation, it's a little bit different. And I like to think of spinal manipulation as the closest thing to exercise that's not exercise. What I mean by that is the neurophysiological changes that occur when you take a joint past its in range into that paraphysiological range is quite profound. And the reason why I know this is because I wrote over nearly 200 pages on it with my PhD. We're looking at not only a physiological or neurological response, but a neuroendocrine response. We're looking at the body responding to the adjustment in so many ways, it almost ceases to be passive anymore. And I'll probably get a lot of hate for saying that, but it's like when you forcefully take someone's joint past that range, I understand it's technically still passive, but it's very active in the nature of the neurophysical response. We're talking an increase in proprioception. We're talking an increase in actual strength output for a short amount of time. And now there's studies coming out of New Zealand, Auckland, showing feed-forward activation, better step reaction time. I mean, what are the implications possibly for helping people in the rehabilitation space, especially the elderly, if you can help someone walk better or have a better step reaction time, even if it's in the short term, right? We take caffeine, we take drugs in the short term. So we talk about this a little bit in the study that I've done with Dr. Mike Woodbury, where we look at proprioception from the CT junction adjustment. And we actually talk a little bit about the application of spinal manipulation in rehabilitation for the elderly, because I think it's a powerful thing. Obviously, when you're dealing with the elderly, you're going to have to make sure that you do the appropriate checks, right? So you're not like breaking someone's leg, arm off because they've got no more density in the bone. But you kind of get what I'm trying to say. So it's that thing when it comes to spinal manipulation, there is something like kind of special about it. You can kind of just like go and like blow up, do the flying seven and just blow everything up. And it's going to have a global effect. It's going to help someone feel better and whatnot. You just have to be careful, because if you're moving a joint that is already hypermobile, that's going to have a negative outcome. And so it's being able to actually feel under your hands what needs to move. And then there's so much research against palpation and against joint play and even against motion palpation. There's so much research against that you can get into muddy waters, because other professions say, well, you can't feel shit. And because you can't feel it, how do you know what to adjust? And thus, if you're adjusting the wrong segment, that can be potentially damaging. So do you see where I'm kind of going with that? Yeah. And so anyway, coming full circle, I just think that it's important. Passive treatments have their place. Active treatments absolutely are the most important. But if you don't have the knowledge on how to prescribe it, you need to learn because you're going to hurt someone. But do you see like the logical leap I'm taking with the analogy of the exercise thing and talking about how it's just like there's a lot going on when you adjust someone, and you can't just kind of go through and just blow everything up. Although I know some people do that. I mean, what's your opinion between in the chiro world? There's like two different sides, right? There are people that treat adjustments just like a muscle rub, right? They just bam, 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 everything gets lit up. And then there are people that treat it like most recently, there were people talking about bedwetting and things like that, And so, like, what are your thoughts on those two very extreme sides of the coin? And where do you sit in between those two?
So, unfortunately, I did go to a school where they talked about adjusting and bedwetting. So, yeah, I'm just going to not talk about that. But yeah, I tend to fall on the category of I don't adjust every single segment of the body because it probably doesn't need it. Yep. I find where there's the most restricted area, also relevant to whatever their complaint is, whatever their functional deficit is. I implement all of that into my decision making on when and what to adjust, or when and what not to adjust as well. Because sometimes you just don't want to adjust something. Sometimes you do want to adjust something. Like, I know like the big thing is like not adjusting really bendy or hypermobile people, but we know that there can be an immediate response in so many things that you just talked about with the adjustments. So under the right circumstances, maybe you do need to adjust something there where a lot of people would say don't do it. But if you're being patient centered and you're trying to take care of your patient in front of you, if they're in moderate to severe pain, and you can do something to take them out of it, and you know it's not going to have any long-term deficits, no potential for injury because you're aware of what you're doing, then do it.
Context.
Yeah. That doesn't mean like someone with like severe RA and flexion extension view proven instability of the upper cervical spine to go blow up their atlas. Like that is never okay. But someone who's just very, very bendy and they have some pain at a junctional area that you can't really get to very easily, but you know it needs to be adjusted. So if you can do it, get it done. Try to help the patient move better, feel better.
Yeah, it's.
I hope that answers your question.
Yeah, it does. It does. I've been having some really cool conversations with people reaching out on Instagram, asking questions about some of the posts I put up, because I've been challenging some of the more mainstream, let's say mainstream to chiropractic, not mainstream to the mainstream, but mainstream and chiropractic things that are taught around SI movement, SI adjustments, certain things around the Godsend system. Like I put up posts debunking things, and I've got a very strong opinion. I've got the research to back it up. And when people ask me, I have no problem. I send them pages of research. And it's not that I'm saying I'm 100% I'm right, because of course I'm never going to say that, right? Being somewhat of a PhD or somewhat of, a researcher myself, I'm never going to come out and say I'm 100%. I'm going to come out and say, this is what the evidence says. I'm pretty sure what I was taught in school is wrong. And I'm pretty sure this is right. And I have so many people really struggling coming out of chiro school, or even coming out of physio school. Like some people were taught some really old stuff. Some physio schools around the world and osteo schools are taught old stuff still. And they're like, no, like I was taught to palpate the SI, I was taught to adjust the SI, like full on contact, like P to A, thrust, full on. Like they think that clicking the SI back into place. Like they 100% are under the illusion that they are adjusting the SI back into place. And when I talk about the research, they go, well, I've had great results in my practice. And I say, absolutely, I bet you have. If you're thrusting into an area that's not moving, I bet you're having, it's a neurophysiological modulated response. I'm not saying you're not having great response. I'm not saying you're not helping your patients. I'm just saying it's probably how you're communicating that's the ethical problem. And that's what I find with new grads across the board, is the way they communicate is most likely dictated by what they were told to do when they were in their placement. And a lot of the time, it takes 10, 20, 30 years for things to get through the literature and get into the curriculum. And that can be a major problem, where you've got 30-year-old information being taught and told, hey, you need to communicate this way to your patient, when it's not right. It's possibly fear-mongering and it's clinically not helpful. That's an issue, right? So we now, once you get out of college, you now have to learn how to navigate your way through research. For the average person, you do a few research papers on how to read research, understand it. The average clinician doesn't even have a great understanding of p-values. Doesn't have a great understanding of a t-test, h-test. Just some of the basic stuff. Some of the basic biostatistics type stuff they don't even understand. It can be a real issue, because you end up getting generations of clinicians that are skim reading abstracts. You know how we used to talk about, like, it was funny to say, oh, you're just reading the abstract? Bro, that doesn't even happen anymore. You know what people read? The title. Like, it's gotten to the point where people are reading the title. Like that study on flexion. It says, like, flexion under load, is less efficient. This is the title, and people were posting it all around. And then when you go in and you look at it, and this was actually done, I think I may have already briefly talked about it, but when you look at the study, you understand that when the person flexes, the physiology of the muscle changes based on the position of how it attaches to the spine. The muscles don't do their job as they're supposed to. More force gets pushed onto the passive structures, right? So now the system's working less to do more weight, and they call that efficient. So it's like, by what motherfucking metric are you calling that efficient? So you really have to look beyond the title, and I would encourage anybody who's listening to our podcast, regardless of if you're graduated, if you're a first year, if you're a second year, if you've been around for 10 years and you think you know it, or you've been around for 30 years and you think you know it all, because your whole worldview is built upon what you see in your clinic. I totally understand that experience is important. I'm just saying, get back in the habit of reading a paper a week. Get in the habit of starting to look and reading something a day, a few pages a day, whatever it may look like. I know some clinicians laugh and go, oh, I know for like people are like, oh, I'm way too busy to do that. The minute you get too busy to be open to new things is the minute that's the moment you're not giving your best to your clients. And that's a harsh reality that people need to probably understand. I know people are busy, and it's fantastic that people are out there serving their community and getting people out of pain like yourself. That's awesome. But everyone has to be committed to growing, and that's why you guys have your continued hours that you have to get, right? Every profession has their own type of continued professional hours, right? So I mean, it's
that's
interesting.
Also why I do my peer review for a journal, because it forces me to make time for it, because I don't ever want to be that person that says, oh, I don't have time to review research. So when
what
it's
journal is
thrown
that?
at me, what
journal is that?
is the International Journal of Massage and Bodywork.
Nice.
Yeah.
I might submit something.
Don't tell me.
The other day, I got asked to suggest a peer reviewer. I'm like, how does that work? I'm like, isn't that bias?
Yeah.
They're like, do you have? They're like, suggest 2 or 3 people that can review this for you. I'm like, I typed in, I'm like, this is bias. And then I literally, after I thought about it for about like half an hour, I went back and I deleted my submission. I was like, I'm not submitting to this journal.
Yeah, good idea.
I was like, that's that. I was like, that kind of seems dodgy. A good journal when they say no a lot. Like my case study I had got pushed back 3 times, and that's not even that many. Lots of people get it pushed back, but I'm waiting on the 4th. It might get pushed back a 4th, but that's fantastic. Like they hit me
it
up
means they're
about
actually
things.
reading it.
They're hitting me up about things that I don't know if it's maybe preference, but like they were like hitting me up about little things that I kind of should have known, and I just didn't pick it up over the years or whatever. But they're like, no references in the abstract, and I was like, oh, whoops. Like I just for whatever reason I had references in the abstract, and that's apparently not that's frowned upon. Yeah, it's just something I heard over the years, but you just don't necessarily think about, and then you forget and you leave them in, and then but then there are multiple things they picked up on. It was fantastic. It was a learning experience, and I'm open to that. Like I said, the minute you get too arrogant, obtuse, and aggressive in a sense, to the point where you're not going to change anymore, you've already lost, right? Especially when we're treating patients. We have to work on being more open and being more acceptable of changing our position on certain things, because ultimately science is going to change. Like ultimately the stuff we're doing is going to slightly change over the course of our lifetime. We've got like 60 years to go, 60 maybe. Are you gonna work till you're old or retire early? Our generation's all about working, isn't it? Really, like the older generation were like, oh, we're just trying to make it till 65 and then we're retiring. Like my
I don't think I'll ever retire.
My father-in-law is retired at 65, and I'm not like saying anything bad about it. I'm just saying it's that generation, because they really they're fixated on that 65 point. They get their gold card. They can travel for free. Like in New Zealand, when you get to that 65 point, you get money from the government. You can go on trains, buses for free. And I'm like, in my mind, I'm like, I don't ever, like, if I'm at the point where I'm feel like I'm too physically impaired or old, like too old to practice, like to adjust and to practice people, whatever, then I want to be teaching, or I want to be mentoring, I want to be passing the torch, or whatever. Like same thing as you, I don't really see, but maybe that's because we're really passionate about our jobs.
It's funny you asked that though, because I remember in chiropractic school, they asked us like, how long do we plan to be a chiropractor? And I was like, forever. And a lot of my classmates were like 10, 15 years, maybe 20 years. I'm like, why? Why would you spend all that time, all that money? Why'd you invest so much time and energy, sweat, tears, so much time of your life that you can't get back to only do it not even like an eighth of your life? Like, I don't understand it.
Yeah, no, this is a similar thing when they said that to us in chiro school. Like, lots of people were wanting to just like use the chiro degree and like eventually move on and do other things. I suppose in our lifetime, I think it's like people change jobs like 3 times now, as in like 40 years ago or 50 or 80 years ago, or even during World War I or II or whatever, like that, those types of seasons in history, you know, you did what your dad did, and you probably had one job, you know, and now we have access to so much knowledge that we have the ability to change and educate so rapidly that you can work your way up in multiple areas and careers and still be successful. Like, it's pretty impressive. But anyway,
It is.
Any other thoughts from you?
I don't think so. I think this is a pretty good wrapping up moment.
Yeah, man, I enjoyed it. Always good to talk to you, and I'm looking forward to some of the guests that we have coming up. I sent you that post the other day that said, I think it said like every podcast that's gone over 3 episodes is like within the top 99% like success rate, because so many people start a podcast and they never go past the first episode.
Yeah.
And then something like if you get to 10, you're in like the 99.999 percentile or something. And I was like, we're getting to 10. But well, that's probably what we're going to do is we'll probably go to 10, and then that will be like that will be like the first season, and then think about how we want to contextualize season 2 and what people want to hear. You know, lots of positive feedback from the people we've had on, and we're going to have more awesome people coming on. So that's cool. And hey, I enjoy these conversations myself. Yeah, not bad.
They're great.
A little bit earlier today. What's the time in the old US of A?
6:49.
But anyway, it's been a good discussion, and don't work too hard. And I will see you next time we have an episode. Hopefully I think next time we'll probably have a guest on, so I'll be excited.
Strength and Chiro
And
podcast.
we'll shoot the shit as always.
Introducing your host, Dr.
All right, man.
Chiropractic, Stephen